introduction to Dr. Martin. He is the Emeritus Professor of Pediatrics.
Not emeritus,
You are still active, right? Okay, and
maybe next time.
Next visit. And of course, he is the editor of the very famous textbook in neonatology, which all of us have memorized, right? The Avro and Fanaroff textbook of neonatology. 3 copies to all of us here. So he's going to give us a very vague title, but it's a very incisive talk focusing on intermittent hypoxemia, which is very important to our little babies nowadays. So Rahul will flash this up again at the end of the session. If you want to record this onto your Google form for proof of attendance and for a very beautiful certificate illustrated by Rahul. All right, so I shall stop share now and hope this works. And over to you, Richard. I'll bring up your talk. This one, right?
It's not the beginning.
No, no, we will get there.
Terrific.
Okay, got it?
Yes, okay, started recording.
Over to you.
Is this facing the right way, do you think?
It's facing you.
It doesn't look like it is. That's right. Okay. Thank you. So, good morning, good afternoon. It's great to be here. It's a very special place for me in my life. And we're going to talk a little bit about life's experiences, throw in a little bit of science and see how we go on the way. And thank you all very much for this invitation. So why am I showing this slide? This is where I sort of hung out as a kid. I'm a frequent flyer at the dermatologist to prove it. Clearly, surfing was not going to be my career trajectory. My parents were wartime immigrant refugees, and surfing wasn't it. So I tried it off and went to medical school. I think the reason for showing this slide is that you can never quite tell where you're going to, from your beginning, where you're going to finish up. And I think that applies to looking around the room. There are many with international backgrounds, and I think you never quite know where you're going to finish up. So I actually, let me just go back. I went to medical school. I was young. I went to University of Sydney. I was rotated at North Shore. I did my 2 years of residency, 1 year of pediatrics, and decided my wife and I had got married. We wanted to travel. I was quite happy to become a GP with maybe a little bit of background in pediatrics. And we went to the University of Missouri, where I was for 2 years. And I was sort of being a chief resident there. And then a lady came called Betty James, and I don't know whether I don't know whether there's a way of, are people seeing the picture?
We can see her.
Okay, and you're not going to know her. She's deceased now, but she had just graduated as a neonatology fellow from the University of Colorado. And sort of, I guess I was about 25, and a light bulb sort of went on. Neonatology, this is cool. We're talking 1972, very early days of neonatology. You can put in catheters. You could intubate babies and ventilate them, which was almost invariably unsuccessful, but you could do a bunch of stuff. And I applied for a fellowship in neonatology. I sent out 3 applications, and I got 1 job. I sent an application to San Francisco, to Denver and Cleveland, where there were 3 established or establishing programs in neonatology. And this is not moving on, boss. I may be doing something wrong, I'm not sure. And as I left me, I'm going to talk about getting advice from people. This was the advice I got from the department chair in the early 1970s when I left me advice for a neonatologist. This is a very risky move. A solution for prematurity is at hand. And then what are you going to do? The other solution, the other advice I had was avoid respiratory research, because it had been discovered that surfactant deficiency was the cause of respiratory distress syndrome or hyaline membrane disease. And that's fine. And no one was ever going to be able to do anything about that. This was at least 10 years before Fujiwara in Japan gave surfactant down an endotracheal tube. It was inconceivable that that would be a solution. So I'm just going to go through some of these different things and just say a few words about each. The first is to seize opportunities and mentorship. I arrived in Cleveland 50 years ago. 50 years ago, almost, right? And I was introduced to three amazing people. And I think that sort of turned, this was Marshall Klaus. You probably don't even know the name. He's one of the pioneers of neonatology from the 60s. This is F. Fanaroff, whose name is familiar to all of us in neonatology. He's retired. Marshall is deceased. Ab is retired for many years now, but he's still a good buddy and a good friend, and we talk constantly. And this is the late Maureen Hack, who was one of the pioneers of neonatal neurodevelopmental outcome. There were sort of three pioneers. There was Maureen, Sir Royce Segal at McMaster, and Betty Vore at Providence in North America anyway. Maureen's contribution, sort of interesting, things that are so obvious now. What Maureen contributed was really that if you look at the neurodevelopmental outcome of preterm infants, you really have to socioeconomically match them to term infants, which is like, that's pretty obvious, but that was not obvious at the time. And she did things which you couldn't do today. She would go to the school actually in Cleveland and ask the teacher, excuse me, I've got this form of preemie. Can you tell me who the neighbors are? Give me the address of the neighbors. I want to go there and check them out. So things were different in those days. Now, Marshall Klaus was the second author on this paper in 1969, looking at apnea. And that paper was concluded with the very strong statement that continuous monitoring of respiration in small infants is now clinically feasible. Interesting, huh? I mean, that was a sort of a breakthrough. Can you imagine having a kid without respiratory monitoring? And I was asked to do my research, and I had an interesting, Dan, I had an interesting conversation. We, in North America, we all have to do a research project as part of our 3-year fellowship. It's a 1-year project. At that time, when I was around, it was a 2-year fellowship. And it's sort of interesting, isn't it? On the one hand, most graduating fellows don't do research later on. So what's the point? I would take the point that if I hadn't been exposed to research, my career would have been very different to what it is now. So you could take that either way. So I decided on understanding apnea. Now, in 1972, I think it was, there was the first paper on CPAP. CPAP for the treatment of respiratory distress syndrome came out of California from a pediatric anesthesiologist by the name of George Gregory. And what subsequently, of course, the kids were on CPAP for their respiratory distress. They never got surfactant, of course. They came off the CPAP and they started having all this apnea. So and this was documented by John Catwinkle, who subsequently, I think, pursued more work with resuscitation. And this is sort of the data that he came up with. And you can see that almost every baby during CPAP had less apnea. And my job, I was told, okay, your research project is to sort of figure this out. How is CPAP helping apnea? So I did the following project, which would be unthinkable today. I got permission from the Institutional Review Board to give CPAP to about a dozen healthy term babies in the regular nursery. That was at a time when mothers stayed in the hospital forever, about a week, whatever it was, especially if you had a section, right? Not like today. So I gave these babies CPAP. And what you can see was the mask pressure goes up, and there you can see a flow channel and a volume channel, and their expiratory time gets longer and they slow down their breathing. And that's what's called the Herring-Breuer reflex, which most of you have long since forgotten about. The Herring-Breuer reflex is very potent in babies. It sort of prevents them lungs from turning into balloons. Can you imagine that? It sort of prolongs expiration. That's its main, it prolongs expiration. If you prolong expiration, you'll slow down your breathing and you'll prevent lung inflation. And in fact, I think this is today the mechanism. When we put a baby on CPAP, they immediately slow down their breathing. And I published this, as you see, in a physiology journal, but now there was a problem. This made no sense. Okay, here I was trying to figure out why CPAP helps apnea, and all I've shown is that they breathe slower. So message is you can do one paper and you can sort of call it quits and say this doesn't make sense, or you can persevere. And I think it's important sometimes when you're a fellow, you've done your first research project, don't quit. Just sort of hang in there like Julie and others have done. And in fact, what happened was we figured this out in the late 1970s. Others did too, that in fact, here you see this is chest wall movement in the middle tracing is equivalent to what the impedance monitor tells us, right? And the impedance monitor tells us this kid's breathing. For about 10 seconds, there's a pause, the chest isn't moving, and then the kid starts breathing. But if you measure tidal volume, which is actually, you can see this kid has there's the long episode when there's no ventilation going on. And this baby is obviously obstructed his or her upper airway. So what's happened is short pause, baby starts breathing. We don't have this. We don't measure ventilation on this baby typically. Fortunately, we had heart rate tracings at the time. No pulse oximeter because they didn't exist. And you can see this baby started developing bradycardia. And this would have been called probably a primary bradycardia, which is ridiculous. In fact, there was a period when we were treating these kids with atropine to prevent the bradycardia. Anyway, another story. So what we actually were able to recognize, and I think there's some sleep folks here, and of course, adult pulmonologists live in a world of sleep apnea and CPAP. A lot of people are on CPAP if they've got sleep apnea. And actually, we recognized before they did that CPAP actually seems to splint the upper airway. And you can see so I started investigating all these upper airway muscles, as you can see here, which fire both phasically and tonically with breathing. The most important is this big guy here, also known as the tongue, which sort of contracts to maintain upper airway patency. And I think this is still accepted today, probably, that CPAP for neonatal apnea works by increasing FLC, as a result improving oxygenation, but also plays a role in decreasing upper airway resistancy and sort of splinting the upper airway. Now we're sort of around 1980, and so that was all very well. A new technique appeared at that time. It was called, this is actually the second edition of the first neonatal text that we had in North America from Klaas and Fanaroff. Something new appeared. It was called transcutaneous oxygen monitoring. And I don't know whether any of you have ever seen one of these deals. I don't have a picture of one. These little electrodes that would measure transcutaneous PO2 and transcutaneous CO2 eventually, and they were heated. And now you put them on the skin, and you were actually able to get a reasonable estimation of arterial PO2. This was sort of amazing. I mean, we were measuring blood gases like most of you do today, every 6 hours, maybe every 4 hours if the kid is sick. We had no idea of all these fluctuations in oxygen. You couldn't possibly know if you measure PO2 every 6 hours that the oxygen is bouncing all over the place. And a series of studies I was involved with followed. This was a former fellow, Chris Gleason. She subsequently became the chief of neonatology at Hopkins. And this is sort of an example. This is what happened when my baby got a spinal tap, okay? We sort of scrunched the kid up, put in the needle, and look what happened to the oxygenation. Probably underestimating things a little bit, not too much. CO2 went up a bit. We had no idea and a whole series of papers we were actually able to publish showing how there are really these enormous fluctuations in oxygenation. Here's another example of a study we did. Here we were looking at what happens to a kid during feeding. Here we were, the baby was fed through this nipple. We had a nasal mask which measured ventilation, and we had these non-invasive monitors on the baby. And for example, we would often see this in a preemie. So here's a baby, or it could be a late preemie typically. You give the baby, you start feeding the kid, okay? And the kid loves eating. And this is measuring sucking pressure, suck, 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 suck. This kid goes on for 20 seconds, takes a pause, takes a whole bunch of more breaths. Now, every time this baby is sucking, he or she is swallowing, okay? Now, fortunately, every time you swallow, you close your airway for about a second. That's sort of a good idea, okay? And you can see if every time you swallow, you close your airway, you're not going to be breathing very much. So this guy actually finished, I think he was an Australian fellow. I think he finished up in Townsville or somewhere. I don't know whether any of you know of him or not. But the point being that a lot of these babies that would come over to the NICU, they would have a dusky episode during feeding. And they could get $1 million workup, right? They could get an EEG, they could, the neurologist would get involved. And all these poor kids were doing was trying to learn how to coordinate sucking and swallowing and breathing. And obviously, well, then what happened was babies started developing bronchopulmonary dysplasia and preemies were starting to survive. And the transcutaneous PO2 monitor was not very good as these kids' skin matured and they got older. And we entered a world of, this was one of our publications, we entered a world in the mid-1980s of pulse oximetry with some degree of so this was the old system and this was pulse oximetry. This is a baby, actually these babies, this is a transcutaneous PO2 monitor on this baby. Looks like she's on CPAP. You can see these little red marks, they went away. This was from the heating, a little bit of erythema. And we were a little bit skeptical about pulse oximetry taking over because you all know the limitations of oxygen saturation, right? If your pulse ox is reading 98, you don't really have much knowledge what this PO2 is. It could be 100, it could be 300. So we were a little bit, I think that was what it was. Pulse oximetry was easy to use and it's obviously here to stay. So I'm talking about sort of taking opportunities. I think my advice would be to the younger folks in the room, take opportunities when they come. And if you don't take the opportunity, then sort of give a good reason why you haven't done it. So there was a manual of neonatology written by Richard Martin, who's deceased, and Fanaroff and I, we were young then, in 1983 took over the third edition of this text. And I think we're now doing edition number 13. And it's been a great experience. And I'm grateful for that experience and have learned a lot in the process. So take opportunities. Now, I went a direction which most of you probably won't go. I don't know how much opportunity you might have, and that is to learn from animal models. Now, I'm a clinician. I don't have a PhD. If I'm going to do an experiment, it has to be translationally relevant. I'm not a neuroscientist. I am a professor of physiology, but that's because they need me in the Department of Physiology, because physiology, all they do now is totally very basic cellular calcium signaling, and they need someone that knows a sort of about lung volumes and things. And I had 2 neonatal animal experiences. One was with the piglets and one was with neonatal rodents, which is ongoing. Now, piglets seemed like a great idea. Piglets are 2 kilograms. I like things that are 2 kilograms. I can deal with them. I can do procedures on them. And they're actually quite good for measuring respiratory control. The problem is you can't use it as a model for neonatal lung injury. They're so mature. I mean, we would have piglets, we would intubate them and we would ventilate the crap out of them, okay? And then after 3 or 4 days, hyperoxia, high ventilation, take out the tube, the piglet's fine, no problem at all. I think they just mature at birth. So I don't encourage anybody to use a piglet as a model for respiratory control. But for control of breathing, they were quite good. So this is a study I did with one of our more successful fellows, Wally Carlo, who has now really set up a program that's wonderful at the University of Alabama. And Sri's friend Amble is active there. So this is, for example, some piglet data. Here we gave the piglet CO2. Minute EMG as a percent is the same as minute ventilation. You're just multiplying EMG amplitude instead of tidal volume and rate. So this is equivalent to minute EMG. And now CO2 goes up. And look what happens to the diaphragm, okay? This is blue, the triangles. Diaphragm kicks in and shoots up very nicely. And the upper airway, as represented by the genioglossus, is sort of asleep for about half a minute, and then it kicks in. And I think what happens in these kids who have a central apnea that then obstruct is that they quit breathing, everything stops, their CO2 starts going up, their oxygen goes down, their diaphragm starts kicking in, the upper airway is closed, the upper airway muscles are not activated, and then this whole thing gets complicated by an upper airway obstruction, which lengthens the whole event, and that's where potentially I think CPAP comes in. This is a study by someone who is on the call, wonderful lady by the name of Pakapan Kirchusik, and I'll talk more about Thailand at the end. She's the head of neonatology now, head of pediatrics now in Khon Kaen University in northern Thailand. So at this time, we're now about 2000. It became fashionable in North America. I don't know whether it became fashionable here or not, to decide apnea is caused by reflux. And all these kids were getting anti-reflux meds to treat their apnea. And what Pakapan was able to show in this piglet model is that, in fact, if you decrease respiratory neural output, as a consequence of that, you start losing lower esophageal pressure and tone. So one thing about gastroesophageal reflux at all ages that everybody agrees with is that it's related to relaxation of the lower esophageal sphincter. And you can see that both phasic and tonically that is decreased. So in fact, we made the case from this that if there is a temporal relationship between reflux and apnea, it's probably the apnea that's causing the reflux and not the reflux causing the apnea. So when this paper appeared, this is I don't know if you know him, he's in Adelaide. Amari is this is a few years ago. I think he's a PhD. And he was able to publish in the Journal of Pediatrics. These are now babies, okay? Lower esophageal sphincter pressure. And you can see it's fine. This is, I guess, the median. This is the median, and this is the interquartiles. You can see the kid has an apnea, and then there's a loss of lower esophageal sphincter tone, which would be presumably a precursor for reflux. So if there is a temporal relationship between the two, and I think the animal data supported that, it's probably the apnea that causes the reflux. And in fact, what probably put a nail in the coffin for anti-reflux meds is this work of Julie Di Fiore. You may know the name. She's a research engineer who joined me nearly 25 years ago. She's awesome. And I know that this Julie has used my Julie, your Julie has used my Julie
Lots of us.
on a symposium last year, and she does a great job. So here you see the percent of cardiorespiratory events, apnea, bradycardia, that are preceded by reflux, okay? It's negligible, okay? It's 3%. So even if you didn't believe what I just told you, you're not going to do very well with these apneas and bradycardias if you treat the reflux. Well, we abandoned piglets at that point. They were good for respiratory control. There's a few other studies we did, which I won't get into. And we decided, let's go with neonatal rodents. Now, there's a real advantage to neonatal mice and neonatal rat pups. They're about 28 weekers, okay? I think most of us, they're between neurorespiratory maturation, they're about like 28 weekers. They grow up real fast. So by 3 weeks of age, they're probably 2 and 3 year olds, which is sort of nice. By 6 weeks, they're sort of reproducing and stuff, I think. So, for example, if you're interested in longer term outcome, for example, we talked earlier today about the problem of BPD as a diagnosis, but I think what's important in these kids, in these preemies, is respiratory morbidity later on, wheezing, respiratory hospitalizations. That's really what we should be looking at. So neonatal rodents are not bad. If you want to know whether a 3-year-old is wheezing, they're survivable. So you can expose a neonatal rodent to, for example, oxygen, which is one of Julie's pet things, and they maybe for a week, and then take it away. They'll survive, not too expensive. They're amenable to genetics. They're inexpensive. So if a whole crop of neonatal rodents is killed by a fellow, it's not a financial disaster.
That was cheaper, right?
They're cheap. There's 2 disadvantages. They're done small. They're small.
He's in the
And they're very small, okay? And they're not babies. So just to give you an idea of some sort of translational messages, Oded Mesner showed up from Israel a few years, about a decade and a half ago, and said, I want to join your lab, Dr. Martin. I want to study bilirubin. And I'm thinking, boy, did you come to the wrong place. I can think of a lot of places where they know about hyperbilirubinemia. This is not my expertise. But we came up with a study where he would look at the effect of hyperbilirubinemia on respiratory control. And he actually did a nice study, which was published in Peds Research, where he sort of figured out, with help from the bilirubin gurus of the world, how much bilirubin to inject. He found it was staining the ventral surface of the caudal medulla, which is a real important respiratory control area, and he found respiratory control was actually inhibited. So there may be a story, which some people are actually looking at now, there may be a story between hyperbilirubinemia and apnea. For example, here's a paper that came about a decade ago, that the prevalence of symptomatic apneic events in reports of acute bilirubin encephalopathy, which hopefully none of us would generate, suggests should be that this clinical finding should be considered a sign of bilirubin neurotoxicity. So why am I telling you this? I'm just, you don't want to wait for these jaundice kids to get apnea. What I'm telling you is that I think you can use animal models to be translational and mechanistic. So, okay, having devoted now about half a century of my research life to apnea, who cares? Does apnea matter? I remember someone telling me about 10 years ago, it was actually at a Hot Topics meeting. He said, you know, why are you studying apnea? It's an epiphenomenon. What's an epiphenomenon? Well, it comes and goes. You know, preemies have apnea and the apnea goes away. Who gives a hoot? You know what I mean? I was a little disillusioned. So does apnea matter? Well, I would make a case that it does, okay? It serves as a biologic link between the lung and the brain. It may contribute to pulmonary morbidity, if nothing else, by the need of increased respiratory support. So it may be that what we do for the apnea, which is ventilation by various modes, is injurious. In our setting, and probably as yours as well, it prolongs hospitalization, which means the hospital administrators and the insurance companies are not happy because you're costing them money. And it causes intermittent hypoxia and its potential consequences. So my interest has switched, for obvious reasons, to focus a little bit more on intermittent hypoxia. And certainly there's a very extensive literature, and you sleep folks in the back know this probably better than I. There's a very extensive literature, animal model literature and adult models, so intermittent hypoxia, for example, associated with obstructive sleep apnea. For example, patients with emphysema who have an additionally obstructive apnea have worse prognosis. So it seemed reasonable to look at intermittent hypoxia. Quantifying apnea as a predictor of outcome is a problem. Quantifying respiratory output is difficult. Apnea, it's hard to measure apnea, actually. You can't use impedance monitoring. You can't use nursing records of apnea, as much as we all love nursing. It's just not accurate. And to measure obstructive apnea is complicated. So intermittent hypoxia has arrived. The other thing is, of course, if apnea is prognostically important, it cannot be assessed during invasive ventilation. Periodic breathing may be a marker of maturity. I may get a chance to say a word about that. So there's intermittent hypoxia. Now, the problem with intermittent hypoxia as a prognostic marker, it's not just respiratory control. It's really immature respiratory control superimposed upon lung airway, lung problems, pulmonary hypertension, low baseline oxygen that aggravate intermittent hypoxia and may be the etiologies for possible adverse neurorespiratory outcomes. So intermittent hypoxia is really the consequence of immature respiratory control superimposed upon a low FRC and otherwise compromised respiratory system. So pulse oximetry arrived. I'm going back in time a few years now. This is Wally Carlo, who, as I mentioned earlier, is now at the University of Alabama. This is another fellow who's done very well. Estelle Goder is the academic chief at the Hospital for Sick Kids, which is a wonderful place in Toronto. Here you see a tracing a bit like what I showed you before. Here's a measure of abdominal excursion, 10 seconds down here, measure of abdominal excursion, a few obstructed breaths there, a few diaphragmatic wiggles. Chest is doing the same. There's clearly no airflow, as you see. This sum is sort of a semi-quantitative measure of tidal volume based on these tracings. So there's no effective ventilation going on for about 10 seconds. And look what happens to the pulse oximeter. Goodness, it starts at 95, it goes down to 67. I would like to think if any of us held our breath for 30 seconds and put a pulse ox, nothing's going to change. Maybe if you're an athlete like this guy, you can hold your breath for 2 minutes and maybe your pulse ox will go down. I don't know. But it sort of boggles my mind that these kids desaturate with just a 10-second pause. They must have no respiratory reserve. There must be, I don't know, no lung volume. This is sort of, I just showed this as an interesting story. So about sort of disappointing in a way. So about a decade ago, I joined the editorial board of a journal called Neonatology. It's quite a good journal. And they said, as part of joining the editorial board, we need you to write an editorial. So I took one night, I think maybe a night and a half, and I wrote an editorial about intermittent hypoxic episodes, and I called it, Do They Matter? And that thing gets cited more than anything I've ever written. And the papers that I've spent months slugging over, nobody could care less. And this silly editorial that I wrote, everyone's side. So I don't know, Julie, what's the message?
Join the editorial board. I'm on it too. They're chasing me.
So this is Julie Di Fiore, who is not Italian, but her husband is. So this was a paper that's also cited a fair bit. So this is on the vertical axis. This was a group of, I think this was 24 to 28 weekers. About 100 babies, no, about 80 babies. And on the vertical axis, you see the number of DSATs they were having. And on the horizontal axis, you see postnatal age in weeks. And there's two things there which have held up over time. The first is, if you look at, the first is that the kids, so we had a hypothesis. Do I have the next slide? No, I don't. I'm going to go back. I'm sorry. So there is some evidence from the work in Boston of, what's her name, Dr. Smith and others, that initially with ROP, you've got hyperoxia, which is impairing retinal vascularization. But then it's the subsequent intermittent hypoxia in animal models that seems to increase VEGF and other growth factors and leads to this proliferative stuff. So we hypothesized that maybe there's an increase in, there's a relationship between number of DSATs and ROP. And in fact, there was. If you look at the curve of the, we defined it as needing laser versus not needing laser. It's a bit soft. There were some questions about diagnosing ROP at the time. And you can see that the kids who developed significant ROP in red had more DSATs. The other thing that this showed for the first time, and many others have showed it, these DSATs don't just seem to start in the first week. And I still don't quite understand that. It's not that these kids on first week of life are on respirators, and that's why they don't have DSATs. In fact, sometimes you can have more DSATs on the respirator than off the respirator, as many of you clinically know. It's not that. There's something that's happening that causing these kids to have DSATs at around 3 to 4 weeks of age. Of course, then they decline. I've got all sorts of theories I won't get into. One is the GABA, which is the major inhibitory neurotransmitter, is excitatory in the fetus. I'm not quite sure of the reason. It's nice when things, that was treated with skepticism. We actually had a bit of trouble getting that published because people say, well, hyperoxia causes ROP. What's hypoxia got to do with this? But it's actually been reproduced. It's always nice when you see something a decade later that's reproduced by somebody else. I'm not sure who this group is, but again, hypoxemic, fairly recent, right, last year, hypoxemic episodes on the vertical axis, and the kids with bad ROP were the red guys. You can see they had more DSATs with increasing postnatal age. Tommy Raffay is sort of, I think, a rising star in our program, was a great guy. And we were looking at the relationship between the development of intermittent hypoxic episodes and the development of BPD. And you can see that trajectory of DSATs again, intermittent hypoxia incidence. It goes up over the first 3 or 4 weeks of life. And it's really starts separating between about 10 and 15 days of age, right, into those that are going to get BPD and those that don't. That's sort of interesting. In other words, obviously this BPD, I don't know the best definition of BPD, I'm not going there, but these kids, obviously, whether it was at 36 weeks, way down the road, these kids were having a diagnosis of BPD made, not at 2 weeks, okay? And you can see that the kids with BPD really started separating at about 2 weeks. This was published a couple of years ago and was followed by this. Same time. Always interesting when people come up with the same thing at the same time. This is the work of Eric Jensen, who's a young neonatologist at Children's Hospital of Philadelphia, and he used the data that Barbara Schmidt had generated from the COT study, which is the, excuse me, which is the study where babies were mainly Canadian studies. I don't know whether you guys were involved in that. I think you had the Australian study, I think. There was a Canadian study where babies were randomized to 2 levels of oxygenation, as you all know. And again, he looked at that data. His statistics was more complicated than ours, a much bigger cohort. And you can see the number of hypoxic episodes per day, even earlier, started to be higher in the kids who had severe BPD with, on the horizontal axis, advancing postnatal age. And I was able to get the 2 of them together, and they wrote an editorial for the American Journal of Respiratory and Critical Care Medicine, looking about the etiology. Let me just say it's complicated, okay? Intermittent hypoxia is here, BPD is there, there's lots of stuff going on, pulmonary hypertension, etc. And so in summary, really, as far as intermittent hypoxia is concerned, this is sort of a cartoon. The work of Christian Poets in Germany has shown that survival may be decreased. Decreased survival is associated with more intermittent hypoxia. There's a group at University of Virginia which has shown IVH is maybe increased. I've just talked about BPD and ROP. This probably summarizes it. These are associations, okay? This is not causal. What are the potential things that are going on? Well, it could be that the intermittent hypoxic episodes are an oxidant stress, which may be pro-inflammatory, and that may be actually bad for outcome. It may be that these kids have intermittent hypoxia because they had a real bad start in utero, right? And if you have a bad start in utero, you're probably more likely to get BPD. And this is sort of, the IH doesn't have a lot to do with it, okay? Or it could be what's described as effect modification, that the IH events, it's what we do for the IH events that causes morbidity. How to solve that problem? Again, you probably have to go to animal models and try and figure out. Association is not the same as causation. Unfortunately, there's different studies that have been done. I'm not going to, I think I'm going to whiz. You want me to quit at that 1:45?
Oh, no.
Yeah, let me just, I'll quit at 10 at the latest, got 10 minutes. So this is, for example, an interesting model that some people have employed. This is a group based in Toronto, I think, where they take a neonatal rodent and they expose it to air or hyperoxia to sort of get a lung injury kind of picture. Hyperoxia in the first days of life gives you a BPD-like picture. And then they introduced them to, there was a subgroup, right, that was introduced to intermittent hypoxia. And then they grew up. And when they looked, for example, at the degree of lung injury, and they measured what's called secondary crests. So if you don't have a lot of these secondary crests, that's not a good lung, okay? And you'll just have to take my word for it that the worst lungs were these guys here. The worst lungs were those where they introduced a BPD-like picture and then superimposed on that intermittent hypoxia. And maybe that's an interesting animal model that should be pursued. Here are some data. Where are these data from? I think these data are actually from the University of Miami about neonatal intermittent hypoxia impairing lung vascular development. There's a very interesting body of work, mainly from Steve Abman and the University of Colorado, suggesting that it's immature vascularization that is driving the alveolarization problem associated with BPD. And they've got a nice model here, this group. This is from the University of Miami, I'm pretty sure, where they had a couple of room airs, 4 groups, right? There's 2 groups received hyperoxia to induce lung injury. Then some of them had intermittent hypoxia cycles superimposed. They went into room air and they were now 3 months old, which is like an adult. And when they looked at, for example, the number of vessels, lung vascular development, or they looked at the muscularization of the vessels, you can see this group here that had hyperoxia followed by subsequent intermittent hypoxia had the least number of vessels, and they seemed to have a problem with increased muscularization, which i.e. pulmonary hypertension associated with that double bang of hyperoxia plus intermittent hypoxia. So that's sort of interesting. It's not exactly mechanistic, but it again, I think is an interesting model. So let me just give a couple of more words of advice. I think it's important to engage in clinical trials. Now, this is, I think, very relevant to what we just heard from your boss, Sri, in terms of NAVA, for example. Of course, respirator studies introduce a whole new level of complexity, but you've got a drug or you've got a medication or you've got a gimmick that you want to improve an outcome. We can call it BPD, we can call it anything. When do you start? If you start early, the infants are more vulnerable to the adverse effects of that intervention. The intervention may not be necessary because if you want to decrease the incidence of BPD, not everyone's going to get BPD. On the other hand, the benefit might be maximized. If you wait, we ran into this with high frequency, we ran into this, for example, with inhaled nitric oxide studies. If you wait, the infants are less vulnerable. At 1 week of age, they're going to be less vulnerable to the adverse effects of your drug. The intervention can be selective. So by 1 week of age, you've probably got an idea who's going down the wrong path, but you may have missed the boat. It may well be that after 1 week, whatever's going to cause BPD or badness has long since happened. So we really need an optimal marker, a biologic marker, a biomarker, to optimally time our new intervention. Can it be clinical? Can it be physiologic? Can it be an imaging study? We need one. There's 4 multi-center clinical trials I was involved with. The HiFi study was introducing, this new thing appeared in the 1980s. It was called high frequency ventilation. These are the different, just a cartoon showing the different forms of high frequency ventilation. And the high frequency oscillator appeared out of Japan. It was called a hummingbird because it went like that, like a hummingbird. And actually we did a study that showed the incidence of BPD 25 years ago didn't differ between the 2 groups. And this study was resoundingly criticized because what happened was it was a new technique. It was a new, sexy new ventilator, okay? And we wanted to do a clinical trial while we still had equipoise, which is ironic, isn't it, in terms of what we just talked about with NAVA, because you guys obviously don't seem to have equipoise anymore on this subject. So we wanted to do it before it became widely known and people still had equipoise. And people said, well, you didn't show a benefit because you didn't know how to use it. You didn't have enough experience with the knobs and the dials and the rate and the pressure. We didn't have a lot of experience, it's true. So we can't win some battles, can you? The CHIME study was an observational study, which my message here would be that an observational study can give you apart from a randomized trial, can give you important information. This was a study, this was at a time when home monitoring to prevent SIDS, preemies in the North America, I don't think you ever caught on here too much for it. Preemies in large numbers were going home on monitors and staying on those monitors for months to try and prevent SIDS, which was in retrospect ridiculous. And this study actually showed that if you looked at the number of apnea kind of events, they decrease over time. We had a group of term babies, this is post-conceptual age on the horizontal axis. The point being that by the time you reach about 43 to 44 weeks, in the preemies, there's actually no significant difference between the number of events they have at 44 and a group of healthy term babies. And that actually had a profound impact in North America to decrease the incidence of home monitoring. Or if on the rare infants you're going to send home on a monitor, you would stop the thing at around 43 to 44 weeks. Then this was a disappointment. There was a series of studies giving inhaled nitric oxide to prevent chronic lung disease. I show this slide to sort of show off because it's the only time I'm ever going to be asked to write an editorial in the New England Journal and provide a figure. I remember they asked the night before for a figure. I came up with this is probably right. I don't know. I think there was biologic evidence that endogenous nitric oxide has a profound effect on lung development. There were really nice studies in a variety of rodents and piglets and sheep that inhaled nitric oxide affects lung parenchyma, airways, and of course vessels. And there was such a hype that exogenous NO was going to prevent BPD, and it didn't. Available evidence does not support the use of INO in routine care of infants. So it's not like the surfactant story. The surfactant story was cool, right? Surfactant deficiency caused IDS. We give surfactant and we solve the problem. This was going to be another surfactant story. Endogenous NO is important for lung development. We'll blow down some nitric oxide and we'll solve the problem. No luck. The PREVED study is a study that's sort of ongoing, and I'm not going to get into that now, looking at the effect of immature respiratory control on later respiratory morbidity. And we're still analyzing this data. I'm just going to show you two slides. Again, this is intermittent hypoxia in a much bigger cohort. No one's going to be surprised that the 22-weekers have the most. They all peak at around 4 weeks. Again, I've shown you this gazillion times now. This is interesting. This is periodic breathing. It's in reverse. This is not a typo. It's the 28-weekers who have more periodic breathing. I think you all know what periodic breathing is, sort of cluster breaths, pause. They can cause desaturations and bradycardias. And it's a sign of maturity. I don't think I knew this. If it was in the literature before, it was buried. And it must be that you need a certain level of organization to produce this kind of respiratory pattern, which obviously goes away as you get older. I think that's interesting. Networking with colleagues is important. I don't know whether you have the opportunities as fellows or young doctors to, this was in 1974. I don't know where I am. I'm here. That's right. There were all these people there. This is a young man called Joe Volpe. You may be familiar with a textbook of brain. This is R. Raju, who ran the NIH. I won't go through all these names, but I think these opportunities you can actually make. I don't know whether you have that here or not, but you can make lifelong. Go to meetings is great and interact like what hopefully we're doing today. And then finally, take interesting opportunities. So this is me in 1968. I was crazy. We were, as medical students, I think we had to do a rotation overseas from the University of Sydney in our prior to final year. And this is me on the Mekong during a war. Was actually in Cambodia. But I was pretty safe at the time. It was just before the what do you call it? Who came and took the Khmer Rouge took over about a few months after I left. So it was actually a fairly, but I sort of fell in love with Southeast Asia. And I subsequently went back to Laos several times to teach a very rudimentary neonatal resuscitation. I think Julie may know this gentleman, Bill Keenan, who's one of the pioneers of the This was the early days of the Heart Association, the American Academy of Pediatrics resuscitation program. And there I am, I'm sweating like you wouldn't believe it in this little room in Laos, realizing that I don't know that I can make much impact in Laos. However, just across the border is Thailand. And I think Pakapan might be on the call. And this part of Thailand, if I've got my geography right, is Khon Kaen. And we were able to establish relations and have fellows come from Thailand to Cleveland and go from Laos to Khon Kaen, which made a lot of sense because there are some languages similarity. And that led to my establishing relations with a lot of the doctors in Thailand. And we've had a conference every year. And Australia, you'll be very proud of the fact that Australian neonatologists who are spectacular are well represented. This is Peter Davis from Melbourne. This is David Tingay. This is your own young lady. This is Helen Liley from Brisbane. We have Peter Dargaville coming in 2024, and we'll give you all a good time if any of you choose to come. We get about 500 neonatologists. This is some of my colleagues. This is my wife, Fanaroff, his wife, one of my grandkids. So I'd like to leave you with this. You can buy into this or not. Success is not the key to happiness. You have to be happy with what you are doing to be successful. Maybe you don't have to, and every once in a while we all have a crummy day, but basically I think your chance of success in your careers is so much higher if you are happy with what you are doing. This is my family. I now have all these Americans, like, well, I can't come back to Australia. I've got the tragedy of having American kids, American grandkids. What am I going to do? I'm sort of stuck there. This is our son, this is my grandkids, my wife, daughter, and so forth. And I have wonderful colleagues. Here I am celebrating, I think they're celebrating my 16th birthday. Cynthia Bearer is my boss. She's the editor of Pediatric Research. If any of you send to her, we also have not quite as international team as you guys do, but close to. And I'm very grateful to my colleagues, and I thank you for your attention.
Thank you, Richard. That was wonderful. We shall stop share now and see whether we have any questions online. Okay, we have one new message. Thanks for the wonderful talk. Why does intermittent hypoxemic events increase as the gestational age increases and subside later? Wow.
Okay, it's a very good. It's actually not okay. So intermittent hypoxia increases as the postnatal age increases.
Yes.
And I don't know why. I've got different theories. One I mentioned is that GABA changes from an excitatory to inhibitory neurotransmitter. But I can't prove that to you. The other is that there are these peripheral chemoreceptors, and this is maybe more than you need to know, that are activated by hypoxia, and they can actually be unstable if they're overactive, and that may be a reason. The periodic breathing, which I don't know whether you caught that on that slide, actually does increase with advancing gestational age, and that's sort of weird. Okay.
A comment from Justine from Newcastle, right? Yes, wonderful presentation and excellent reflection on neonatal.
Well, thank you. And I've met one of your fellows, I think. Is that right? Have I met one of your fellows?
We'll turn the camera around.
Young Dan.
Young King. He's still awake.
I've had a bit of difficulty convincing him that research needs to be an important part of training. He's not sure.
So for everyone online, these are all keen fellows, and they're taking notes on what their next research topic is. Right?
All right.
Any
by the way, research.
They need to ask questions.
I might have made some comments up about that as well.
Where?
No, I think that's
Oh, no, there was
for
another
us.
one?
Oh, that's just Rahul.
Let me just make one comment, and that research does not have to be piglets and neonatal rodents. The vast majority of our fellows, all of whom are required to do research, do patient-oriented research. And I'm not talking about going to the medical records room like it used to be and looking at a bunch of charts, but sophisticated patient-oriented research with an appropriate—
Oh my God, lay it on.
power, with an appropriate power analysis and a statistical method, and that's
Sounds scary to me.
Oh.
it does not have to be. It does not have to be neonatal mice. Okay.
These intimate episodes are, which is really interesting. The baby with bad lungs that can't extubate. It's not only you're talking about them periodic breathing, which is
Yes.
interesting, but they also seem to support or splint on the ventilator, and yet it's absence of breathing though. And what I don't understand is their diaphragm splinting at the time, or are they the tone of the diaphragm, or I don't know whether you observed that
You're talking about kids on or off the vent?
on the ventilator.
So maybe you can repeat the question for the.
Sure. So the question is actually, I sort of caught John's question, but it has to do with what are the I think it has to do with what's going on with these kids who are on a ventilator and are desaturating. And in fact, sometimes if you pull the tube, they do better.
And you look at their, but you also look at their breaths, and they're not having breaths. The ventilator's not able to deliver.
Yes. Well, the group at Miami have looked at a fair bit of this, and they think it's abdominal muscle contraction. Actually, I think a baby that's sort of a bit irritated has abdominal muscle contraction and doing what you're describing. So it's sort of splinting things,
Has anyone tried to put an EDI probe down and actually see whether their diaphragm's discharging?
Well, that's right. That's something we should be doing. Yeah, and we don't use the invasive very much, so we haven't really looked at it as much as we should. Yeah, but that's a good way of looking at the resting tone of the diaphragm, the minimum EDI.
So I've got a question, just because I'm a fan of caffeine for many reasons. Both
I am too.
Everyone's a fan of
I am
caffeine.
too.
Love it.
Based on the desaturations and the response of the diaphragm to caffeine, as far as the EDI stuff, when do you stop caffeine?
Maybe you.
The question from Dan from Newcastle is when do you stop caffeine? And we've got a protocol and it gets changed all the time. We don't use we basically just make a clinical, we make it as a clinical decision. If the baby is more immature, we go a little bit longer. If the baby's got BPD, we'll go a little bit longer. I would say on average, when the kid's around 32 to 34 weeks, if the kids had no episodes, we'd be quite happy to stop the caffeine. The next question, of course, is how long do you have to watch this kid in the hospital? And that's a whole other bone of contention. How long do you have to, if the kid's ready to go home and on full feeds, then you stop the caffeine 3 days ago, can you send that kid home? Because the half-life of caffeine, as you know, is on the long side. We try to watch them for 5 to 10 days, but I can't give you an exact number. But we don't use a physiologic marker like a diaphragm EMG or anything. We use clinically, but certainly, I mean, caffeine, that's a whole other talk. You'll have to invite me back.
So we will,
It's a whole other talk.
Definitely.
It's a whole other talk.
So we need to take 2 questions before time runs out. There's Dr. Rose Boland from the Agency for Clinical Innovation in New South Wales. She is big on preterm stuff. So Rose, correct me if I'm wrong. What you're asking is, does it still stand true that infants born at term can have period?
Yeah. Thanks, Julie. Hello, Julie. So I'm just trying to turn my camera on, but the internet's blown away in Melbourne today.
Just Melbourne.
You've got it off. No, we always used to be taught, that infants born at term had episodes of periodic breathing, healthy term babies. Do you think that still stands true, Rich, or is that a bit of an urban myth from ye olden days when I trained?
Thank you for your comment. It's unusual. There's a lady, I think she's in Melbourne, isn't she? She's done some research on the trajectory of periodic breathing, and I've forgotten her name. She's published a fair bit on
Dawson.
What?
Jenny Dawson.
No, not Jennifer Dawson.
No, not Jen. No.
But anyway, I think periodic breathing in term babies is unusual. Certainly wouldn't worry about it. I don't think anyone has ever shown that periodic breathing is a precursor for problems.
Unless they have another pathology, Rose, maybe like.
No, I just meant, is it part of their normal physiology as they're growing? That, I mean, you talked today about the preterm
Yes,
babies,
I
but
think,
with babies, you think.
I think we wouldn't really know most period. I mean, if baby has desaturation, how would we know we'd really only know in a healthy term baby that the kid's got periodic breathing if someone notices the kid's blue, right? Because no one's going to have socks on their kid, and the pauses are short. I think it's unusual.
Yeah. Thanks. No, I'm thinking about these babies that come in with these, these bruies, these brief, unexplained, interrupted events, and whether that could be simply periodic breathing momentarily and a bit of a blue spell. And of course, the parents bring them into the hospital. By the time they get there, they're pink and beautiful and screaming their heads off.
So there's a question from Dr. Hariram from Bangalore. Hello, Dr. Hariram. I know you well. And I think it has to do with desaturation episodes in PPAP and PEEP. I don't think I would increase. Let me say it this way. If you have a low baseline oxygenation, if you have a low baseline oxygenation, you'll have more desats. It's sort of like skating on thin ice, right? If you're starting at 88 and you decide to quit breathing, you'll tumble down very fast. And that's been shown very clearly, and it's sort of obvious, right? So I would make sure that if a kid's having desaturation, that their baseline oxygen saturation at least is in the at least in the low 90s, right, or even mid 90s. And if it takes PEEP to do that, it takes PEEP to do that. But that would not be a primary strategy. I'm more thinking of making sure they're at a decent level of baseline oxygenation, however you choose to do that.
Okay, thank you. You've got a lot of fans around you. We've got Lily from Sian.
I remember walking.
Hello, Lily.
I remember walking around the walls of Xi'an years ago. Is that the
Yes, terracotta walls. Yeah. Disneyland. Yeah. Okay, we are out of time. Thank you everyone for joining. You had more than 100 people online just then. So no stage fright, right?
Okay,
Yeah.
good organization. Thank you.
Man. Yeah, we survived our first hybrid conference. And thank you, everyone. The fellows here are all revved up, ready to do research. So we have a special fellow day in Bali next year, January 12 to 14. Come along. Spaces will fill up very quickly, and you've got those usual suspects like Steve Adlin and people like that to come in for you to interrogate. So like Richard says, please keep networking, keep your thinking going, because you are our future.
And be happy. Be happy.
Be happy.
So
Yeah.
the only thing you didn't put on the slide was the secret to longevity.
Longevity.
Well, that's part of being happy. What?
Thank you, Rose. Thank you, everyone. And we'll sign off now. Goodbye.
Bye. See you, everyone. Have a good day.